I can say that basically the KMPDC mandate is largely twofold. One is to protect patients, because patients are vulnerable when they go to seek services. When you first get into it, you are doing it from what in medicine we call first principles. First principles is you are learning from the ground and doing everything without formal prior training. Our work is to facilitate people to have an environment where they can safely provide quality health services. Usually, regulators, many people view them as, I would say, the police of the sector. Then the medicines and everything, are they there? The laboratories, the radiologists, are they working? And how do you have all those systems functioning together? Yeah.
Welcome to Daktari Tone, where voices, perspectives, and sounds relating to healthcare practitioners and matters health are amplified. This is a podcast by Daktari Online, created for healthcare professionals across Kenya. Each episode brings you honest conversations, expert insights, and real-life stories from the front lines of care. Hello and welcome to the Daktari Tone podcast, where voices, perspectives, and sounds of healthcare practitioners are amplified. I'm your host, Rian Hilary Kerubo, and today I'm joined with Dr. Kariuki David, our CEO and the Registrar of the Kenya Medical Practitioner and Dentists Council, KMPDC. That role places him at the center of the Kenya's evolving healthcare system, reforms, and regulations. Daktari Kariuki, karibu sana Daktari Tone.
Asante.
You can kindly introduce yourself and let us know a little bit about yourself.
Right. So I'm Dr. David Kariuki. A medical doctor, currently serving as the registrar and chief executive of the Kenya Medical Practitioners and Dentists Council. I've been a doctor in practice for close to 30 years now, serving the public from various places and in various roles. Right.
Okay. Now, before we dive into policy, compliance, and reforms, I'd like us to get to know the human behind the title Registrar, CEO, and 30 years of. You did say 30 years of being at practice. Okay, that's so many years. So when you're not, immersed in the council meetings and regulations, how do you, actually unwind?
Yep. Well, so generally outside of work, I'm a member of several clubs, and I'm a son, I'm a father. So I spend time in all those places, and I also probably a bit of traveling, and a bit of reading and medical books. Yeah.
Okay, so that means you spend time with family. You've also mentioned being in part of clubs. What kind of clubs?
Members clubs, golf clubs, and
so you do play golf?
Not quite, not so often. I'm a learner.
Okay. Okay. Yeah. Also reading. What kind of books do you read?
Just either motivational books or
I was.
Fiction.
That was a trap. I was almost hoping you telling me, I'm still reading medical books. I'm like, how is that different from work and everything?
Yeah, sure.
Okay. Now, what is that one thing about healthcare regulation that people would, be genuinely surprised to learn?
That healthcare regulation is more about helping them to be better at what they do and to protect the public from harm when they are getting services. That's what regulation is about, that many people may not know about. Yeah.
Now, would you put yourself at a place where you say that you balance work and work life? You have work-life balance?
Yes, I do, because I have the time I spend at work, is quite intensive, and there is now the time I spend out of work doing other things. Yeah.
And so that means you do take care of your mental health.
Sure.
Something has been with you since you started practice, or?
Yes. And over time, initially as a young doctor, you are very enthusiastic. You want to learn so much for your clinical practice and maybe specialization. So you tend to spend more time with work. But over time, you now get to balance between the two. Yeah.
Okay. Now I have a few questions, quick fire.
Right.
Tea or coffee during long meetings?
Usually tea most of the time.
You're a tea person. You can ask me a question. You can ask me a question.
Yourself?
Yes. For me? I vary between tea and coffee. Yeah.
Yeah, for me it depends sometimes. But when I do coffee, I do the non-caffeinated.
Okay. Because for me, I do believe tea, every time is tea time. People even get shocked that I can even have tea in the evening or even at lunch. I can even have it with my meals. Yeah. Then, are you an early morning person or a night person?
Mostly early morning. Right. Yeah.
For me, I'm nocturnal. I work well best during the night.
Yes.
And I get to not really love my mornings. Yeah. But then it tells much. I think I've met many doctors who work well in the mornings.
Yes.
Yeah.
Fresh, yeah.
What is that one word that your colleagues would use to describe your leadership style?
I don't know. Maybe we ask them.
What should we think?
No, well, me, I usually accommodate them as much as possible. So I don't know what word I will use there. But of course, when it's time to be strict, then we don't compromise.
In fact, now that even leads me to this question of what is your leadership style? Yeah.
I would say it's probably between authoritarian and just what I'm trying to look for the word. I'll tell you when I get it here.
Okay. Now you've said that you have practiced for over 30 years and you've now trained and practiced as an obstetrician and gynecologist. For how many years now?
So, well, as an obstetrician, it's getting close to 20, and I'm surprised it's getting there. Yeah.
Okay, time flies, So, what drew you to that specialization?
I think right from internship, when I did internship, obstetrics was where I enjoyed most. Seeing happy mothers with their healthy babies, and you see the results that you see, and the satisfaction that you get from it, and the learning that you also get from it drew me. And when I became a medical officer also, the first place I was sent to was the maternity ward, and no one else used to want to be placed there, because it calls for a lot of time to be at the hospital, and it's whether day or night, so emergencies within the maternity wards and the female wards occur throughout. And so I think that kept drawing me, and I thought, why not specialize? And here I am.
The fact that you mentioned that there was, a point when most of your colleagues or peers would not want to be at the maternity ward. For you, was there a specific frontline moment that you had like a delivery room experience or a system failure or maybe a leadership gap that made you realize that medicine alone wasn't enough?
Yeah, very many, because our system has really grown over the last years when I've been a medical practitioner, from the times when we did not have the tools that we needed. A lot of improvisation was being done, to the extent that even when you prescribe, for example, a cesarean section, and not even a cesarean section, before a cesarean section, there is what we call, the medicines that we use to enhance labor, like oxytocin and such. As a very young medical officer, we used to, once you prescribe, it wasn't available in the hospital. So you prescribe it together with, you actually give a prescription, not just on the treatment sheet, but to the patient to have it bought. And many patients probably had moved so many kilometers to reach you, and they are alone. So they even have no one to send. And I thought it wasn't, good. So the same thing when you prescribe for a cesarean, you also give them prescriptions to go buy what you need. And so there were very many gaps and challenges. And that drove me to one day get to know, why don't we have these things in place, and drove me a bit into management. Though I didn't get into management, just by choice. During the times that we were, growing within the profession, I was still, working within the public service. People who were to be managers or the leaders in the hospitals were usually the specialist doctors. So whenever you found yourself as a specialist, one of you would be chosen into it. Many would refuse because we believed we were largely clinicians to do bedside teaching, bedside learning and service delivery, more than office work.
That does tell a lot about you, and the fact that you went head on, and just by not bringing out that the fact that medicine alone is not the solution, there's still system inefficiencies, there's patient safety gaps, and even leadership exposure. And even now talking about management, later, aside from your specialization, I do have an understanding that you did pursue MBA in healthcare management. What problem were you trying to solve with that decision?
Yeah, as I've just said, is that when you first get into it, you are doing it from what in medicine we call first principles. First principles is you are learning from the ground and doing everything without formal prior training. So as I got more into management, especially of hospitals at that time, and I started with maybe from smaller hospitals to larger hospitals, I realized that there's a lot that I am doing, but I would know better if I did some formal training to be able to know how to approach some things which I was finding a challenge. Remember, when you are given a hospital to lead or manage, a hospital is actually a health system by itself, with all the pillars we talk about in healthcare, because you have the human resource, and now it's not the doctors only. Because when I'm a doctor in the ward and maybe the specialist in the ward, I will have medical officers, there will be nurses, but most of the time I'll actually be targeting what I want to the medical officers, because those are the people I work with. Maybe we do a ward round, see patients, decide what we are going to do with each of them. As I move to other activities, I leave the medical officer or the intern, if it's an internship center, undertaking what we have agreed. But the moment you are given a hospital, now even the nurse, the cleaner become part of your team. So now you need to know how to relate with all those groups to be able to ensure that the clients who come to the hospital are well taken care of. So beyond that, you will have the infrastructure. So not every machine will be working every day. So you need to have plans on how you ensure that they are functional throughout, in a way that you reduce referrals from your facility to other places. So all those pillars, then the medicines and everything, are they there? The laboratories, the radiologists, are they working? And how do you have all those systems functioning together? So you do it because you are already there. But when you now do a bit of formal learning, you actually find some decisions you are making. Oh, this is why I was making it. And it becomes more exciting. So it drove me to now do a bit of formal learning through the MBA. And I learned a lot from it.
Yeah, and that tells that you even got to acquire more knowledge and diverse, just not you being a clinician or a medic, but bringing everyone on board in the healthcare system. And now with that, what do you think that most clinicians often misunderstand about regulators?
You see, usually regulators, many people view them as, I would say, the police of the sector. Because one thing we do as regulators is to come up with the minimum standards that are expected of every practitioner. But standards without following them then would mean nothing. So once we have set the minimum requirements and the minimum standards that we expect of everyone, we then follow to make sure that people are complying to them. And if we were not there, then it will be a free-for-all and things will go wrong. Yeah. So, that's the perception and misconception that people usually have about regulators. It's just about making sure that people comply to what is already agreed on.
And now, what must now regulators not forget about the clinicians?
That they are human beings, and so we have to be very objective in making decisions about where we think that decisions need to be made. Yeah, and that they work in diverse environments, and so the decisions they have made, we look at them based also on where one is coming from. Yes.
Now back to your specialization, being an OBGYN on call nights, what's the toughest part?
Dealing with emergencies that were not expected is usually very tough. So that mental readiness and sometimes having to spend very long hours without sleep, at night is usually very tough.
Okay, what is that one habit that you picked up in clinical practice that still serves you today?
Is to always show up. Yeah, you must always show up, because if you don't show up, then you will not even know what happened, and you may not be able to answer for any omissions or commissions that happened when you are away. Because showing up is actually what makes the difference.
Yes. Do you have a question for me?
Not right now.
Okay. Now, if you weren't a doctor, what career would you have chosen?
I don't know. Maybe I would be into engineering or something.
Why engineering?
I think I get fascinated by, having now been into leadership and management. I have supervised a lot of infrastructure coming up, in terms of buildings for hospitals and bringing them up. And sometimes when I go and see how the constructions are coming up, I see it's also something that is very fascinating. How they have come up with the designs and how they have calculated what needs to be where. I think it's fascinating, yeah. Okay. But medicine is still good. Yes.
I can tell, because for the fact that you specialize and then later you still felt the need to, study on, have a formal study on health management, it tells that it's something that you really wanted to know more and pursue more in very many diverse angles.
And you see, now I'm in regulation, which is actually a full cycle for a practitioner.
Yeah. Who needs to understand both sides.
From the learning to the regulation and controlling those providing services. And you see, I've moved from, providing direct service delivery to one person. Now I'm doing it, let's say, for the 50 million Kenyans.
Now, talking about being even on regulation, what does KMPDC, mandate really entail?
I can say that basically the KMPDC mandate is largely twofold. One is to protect patients, because patients are vulnerable when they go to seek services. Meeting people who are very learned, who have a lot of information, a lot of skills. So patients require a place where they can also get to know what happened with their treatment. So that's one arm of KMPDC. The second is to guide the professionals, that with all their knowledge, with all their skills, with all their technologies, there is how to manage their patients and use their knowledge for the good of mankind. Yeah. So those are the two main things, but there is so much now under that we do as KMPDC. So for each, we can get into more details. Yeah. So in terms of guiding the professional, when one is not yet a practitioner, they start from school. There are certain attitudes and skills that one needs to become a doctor. And secondary school subjects, some, their intensity at that level can tell whether you will be able to cope with medical school work, you know. And that's why you hear there are those we say are mandatory, you know, to get to them. So from there, KMPDC, after determining and deciding the minimum entry requirements into medical school, we then have what we call a core curriculum. What do we want people to learn so that we can say they will become safe doctors or dentists or, you know, healthcare professionals. So we set the minimum standards for training. And so for our school to train, we take them through that process and confirm if they are ready or not. Yeah.
Okay. Now, for me personally, and maybe more of us, we only, you know, when we think of KMPDC and how much I've interacted with the KMPDC we always often think of it as a licensing office or as an enforcement body. And even sometimes there's a belief that it only shows up when it's, you know, to close facilities. And I don't know, where does that narrative come from and how accurate is it?
Well, I think it's a narrative and a perception that people have about the council, because I think the only times that people tend to see us is when those things happen, and especially those that become publicized. But like maybe for the last 1 year or so, we've done over, maybe I would say 6,000-7,000 inspections across the country, but probably people hear only one where one patient died. Over the last maybe year, we have dealt with over 150 complaints from patients. We've resolved some are still in the process. Over the course of KMPDC's life, we've dealt with over 1,600, 700 cases. We've determined all of them except about 200. So that's a lot of work that we have done. So we've taken, and many of those cases, we are like the arbiter, the referee between the patient and the doctors and hospitals that treated them. And we very objectively make a decision where we determine whether the complaint has merit or no merit. Yeah.
Okay, so it's great for us to now take note that regulation is essential for as KMPDC's existence for patient safety, professional integrity, public trust in the healthcare system. Anyway, so now that leads me to this question. If KMPDC did not exist in 5 years, what would Kenya's healthcare look like?
I can say maybe there will be no healthcare system. Yes, because everyone will be doing what they want, treat patients how they want, you know, doctors do what they want, patients, everyone.
So that means it's a vital part of the healthcare, of the Kenya's healthcare system.
Without KMPDC and the regulatory work it does, we wouldn't say we have a health system in terms of regulation, because remember, generally we are actually the arm of government that supports government in monitoring what people are doing on the ground. So first, who enters into the profession, so that we don't have everyone calling themselves Daktari and they are not. So we move around checking. Of course, the country is vast, but that's one of the key things we do, controlling who enters into the healthcare market as a healthcare provider, to be called a doctor or a dentist.
Talking in one term of what you've just defined there, it's quackery. Talking
Yes.
about it, what really entirely leads people to, start quackery business, especially?
I think those are people who are probably more money oriented, yes, and not service oriented, yeah. So it's more about the money.
And now, according to you as Dr. Kariuki, what is that one misunderstood regulation?
The misunderstood regulation, I think, like we already said, that it's more about being punitive, yes, rather than facilitative. What we do is actually, our work is to facilitate people to have an environment where they can safely provide quality health services. And usually we say we need to work together with them so that they can do what they know how to do and do it best, as they also make sure that the people they are managing get back to their socioeconomic activities soonest enough.
And you've also touched on inspection. What is that one inspection myth that you would wish that we would die?
I mean, the misconception that whenever we come to inspect, we have come to close.
Yeah.
That's not what we do. Actually, there are very many times that we inspect and tell people, actually, you need to come to us and request for us to upgrade you because you've done well and you need now to move to the next level.
But then why is that the feeling is still there? Because right now as I'm sitting with you here, I feel the calmness. But then outside there, CV and PR.
I mean, I think even you see in town, when you hear kanjo, everyone runs here. So I think it's a general perception, not only in the healthcare, but generally. It has been made to look like regulation is a policing or a punitive activity rather than a facilitator of service delivery.
Yeah. And even the fact that you've also now mentioned that you also sometimes just not inspect and close down, you also request that the facility could come and talk to you for upgrade.
Yes. In fact, most of the times, when we do inspections, there may be several outcomes. We can either tell you are doing well, continue. You are doing well, but there are areas that you require, and then we tell you we'll come back in 6 months or 3 months to find out whether you have done something about what we have said.
Now, talking about
yes.
Sorry to cut you short. What is that one thing, or maybe many things, if you could mention but a few, that practitioners are doing that you feel require recognition?
Most of the practitioners at least comply with the standards that we have given them, and we have tools. So even when we are going around a facility, we go together with them and they see. Many of our practitioners at least ensure they have their annual license to practice. They are registered. They actually tell us that when they have doubts about somebody they are seeing treating, they anonymously tell us, go and check a certain place, a certain person, and we go and confirm, reassure them that in our records, we think they are okay, or they are okay, not that we think they are okay. If not, we take them to the right route. Also, with about the country sees about 2 to 3 million patients, annually. And the number of cases we get, though probably we don't get all the cases, are few, meaning that our doctors are doing the right thing. Yeah. And that's something to be proud about.
Yeah. Okay. And now, for a fact, of course, regulation isn't, happening in isolation, and it happens alongside massive system reforms. And that means you being the leader, especially as a CEO and registrar of KMPDC, your involvement with the UHC, that is Universal Health Coverage, and other health sector reforms. How does, regulation actually support UHC just beyond theory?
Actually, one of the things is that to achieve universal health coverage, one of the key things is access to healthcare, and access not just to healthcare, but quality healthcare at a cost that does not take one to impoverishment. So, it's what we call the iron triangle. You balance between access, quality, and cost. Where KMPDC comes in is one in access. Access means access to the right practitioner, the health worker generally. Access in terms of infrastructure, a health facility, access to medicines and all that. But KMPDC is largely now access to a health professional and access to a health facility. Those ones we are...
You're answering my next question, because there's always tension just between access. There's also tension between the quality, affordability, and now the fact that now you're centering it as for KMPDC is more now the access, that is the facility
and the profession. So what we do is that we are ensuring there are enough doctors in the market.
Workforce.
Yeah, so generally ours is workforce. And because we also have the twin regulatory mandate for health institutions, is registering and licensing health facilities. Because the higher the number of facilities you have, the higher the access. People have more options on where to get their services from. Yeah. So those are the two major things. And of course, policy advisories to the ministry where we think some changes need to be done. Yeah.
And now, what should clinicians and facility owners actively do differently to align with ongoing reforms?
I think one is that they need to learn, the laws, read the laws, understand them, the regulations, then adapt to the changing environment. Because the environment previously is not the same as it is now. So I think it's good for one to be very clear about the current environment and the laws that have been passed and regulations, and then adapt to fit into those. Yeah.
Okay. Now, what is that one small change, that could make a big impact?
In terms of
healthcare systems, access, quality, standardization.
I think the major one is still around financing, and we are making attempts to better financing. And if that can be resolved, I think we would move many steps ahead.
What are the gaps in financing according to you?
In financing for people to access healthcare is pooling. We haven't yet created a large enough pool for people to get the healthcare that they need. People are still getting back into their pockets to pay for health services. And that in some places causes delay, and delays might lead to worsening of disease.
And then prior, you did talk about laws, that the practitioners and clinicians should, get to be well versed with the laws. So according to you, what is that one reform or law that is often misunderstood?
For service delivery or for... I think many don't understand the requirement for being registered and not knowing that it's actually good for them, because then it defines who can be either a healthcare professional or who will not be.
I think then maybe this should be a great time to now you to end with telling us what are the requirements after, let's say, I've now completed school. What should I do next so that I can now be registered and all that?
Okay. I think when one completes school, and now we want to start it from school by doing something we call indexing, so that we can know how many we expect next year and the following year and the following year. It can help in planning. But once one completes medical school, the next step is internship, because medical school gives you the theory.
Internship gives you the practice.
Yes. And KMPDC is actually the bridge between medical school and the healthcare industry as a provider. So one needs to go through internship. It's a 1-year program. After one successfully completes internship, then they become eligible to practice medicine in the country and across the world. Successful completion of internship, one would then come to the council, apply to be registered. And if all documentation is complete and is okay, you get registered as a practitioner. Now that says you can now start practicing semi-independently, because you are still a new practitioner. You may still need guidance here and there. But generally, one can then practice. Once you get registered, registration is a one-off, lifetime, except where we may deregister you for one reason or the other. From there, then, as long as you are practicing, you will require an annual license to continue practicing. And your license can now change as you become more specialized. You can remain at that level as a general practitioner, which is still good, because we need a lot of doctors in primary healthcare. You can learn. When you are back to the university learning as a master's student, we give you a license that we call a registrar license. When you finish, there is also a period we give you to get back on the ground, practice a bit more before we recognize one as a specialist. We give you what we call a senior registrar license. Yeah.
Thank you so much, Dr. Kariuki. Of course, what you've shared with us today will help those young clinicians and practitioners who are still in school studying and knowing the essence of them being registered in the right way. So that's it for this segment. We'll get to talk more in the next segment on what practitioners and facility owners need to know now and next. See you next.